here today. Now, what is anesthesia? So, anesthesia is basically a triad of, it is a triad of metabolic acidosis. Sorry, it is a triad. Good morning, Jammu. It is a triad of right. Why my voice is clear? Now, anesthesia is a triad of amnesia, analgesia, and muscle relaxation. It is a triad of amnesia, analgesia, and muscle relaxation. Right? Now, then what about the important points in history of anesthesia? Important points from history of anesthesia. Now, both the oxygen and nitrous oxide were synthesized by Priestley. Both oxygen and nitrous oxide were synthesized by Priestley. So, Priestley was the person who synthesized oxygen as well as nitrous oxide. Now, nitrous oxide was the first inhalational anesthetic to be used in 1844. Nitrous oxide was the first inhalational anesthetic to be used in 1844. So, sometimes it is asked which was the first inhalational anesthetic to be used. It was nitrous oxide. Now, nitrous oxide provides analgesia. Nitrous oxide provides analgesia, and this property was discovered by Humphrey Davy. Nitrous oxide provides analgesia, and this property was first discovered by Humphrey Davy. He was the first person to discover that nitrous oxide provides pain relief. Now, John Snow is father of anesthesia. John Snow is father of anesthesia. Sometimes the question is asked, who is the father of anesthesia? John Snow. Then, ether was first used by W.T.G. Morton on 16th October 1846. Ether was first used by W.T.G. Morton on 16th October 1846. W.T.G. Morton on 16th October 1846. Therefore, 16th October is also known as World Anesthesia Day. Therefore, 16th October is also known as World Anesthesia Day. Now, cocaine was the first drug to be used for spinal anesthesia. Cocaine was the first drug to be used for spinal anesthesia. It was the first drug to be used for spinal anesthesia, cocaine. Now, the first spinal anesthesia was given by August Bayer. The first spinal anesthesia was given by August Bayer. Aligarh, I can't do that. It was first spinal anesthesia was given by August Bayer. Now, the first endotracheal intubation. The first endotracheal intubation was done by William McEwen. The first endotracheal intubation was done by William McEwen. Again, this question has been asked in the DNB examination. Who did first endotracheal intubation? William McEwen. The endotracheal intubation was made popular by Ivan McGill. The first endotracheal intubation was made popular by Ivan McGill. He was a person who made endotracheal intubation popular, but the first endotracheal intubation was done by William McEwen. Now, the muscle relaxants right. So now we'll start with the equipments in anesthesia. Now, the first equipment is ambu bag. The first equipment is ambu bag. Now, the ambu bag, it comes in different sizes. The ambu bag, it comes in different sizes. For neonates, it is 240 ml. For children, 500 ml. And for adults, 1 to 2 liters. And for adults, 1 to 2 liters. Here, water of crystallization is you just dip them into the water, dry it, again dip them, dry it, so that granules become hard. Right? So this is the size of for neonates 240 ml, children 500 ml, and for adults 1 to 2 liters. Now, the maximum amount of oxygen that can be delivered with ambu bag is 100%. The maximum amount of oxygen that can be delivered with ambu bag is 100%. Now, then next to come is Goodell's oropharyngeal airway. Goodell's oropharyngeal airway. Now, what happens is when you give anesthesia to the patient and the patient becomes unconscious, the tongue falls backwards. Right? The tongue falls backwards. Now, falling of tongue backwards will cause obstruction of the airway. So, Goodell's oropharyngeal airway prevents fall of tongue during anesthesia. Goodell's oropharyngeal airway prevents fall of tongue during anesthesia. Now, the correct size is determined by the distance between the angle of mouth and tragus. Correct size is determined by the distance between the angle of mouth and tragus. Correct size is determined by distance between angle of mouth and tragus. Third to come is LMA. Now, LMA means laryngeal mask airway. LMA means laryngeal mask airway. Now, write down the important points about LMA. LMAs are supraglottic devices. LMAs are supraglottic devices. Second point, they are not definitive airway. Since they do not prevent aspiration, so they are not definitive airway. They are not definitive airway. What are the advantages with LMAs? Advantages with LMAs. They can be used for difficult intubation and CPR. They can be used for difficult intubation and CPR. They do not require laryngoscopy and muscle relaxation. They do not require laryngoscopy and muscle relaxation. And they are easy to insert. They are easy to insert. Disadvantages include one. They do not prevent aspiration of gastric contents. They do not prevent aspiration of gastric contents. And second, they may cause gastric distension. They may cause gastric distension. Right? Then the size of the element depends upon the weight of the patient. The size of the element depends upon the weight of the patient. For 1 to 5 kg, size 1, 5 to 10, 1.5, 10 to 22, 20 to 30, 2.5, 30 to 53, 50 to 74, 70 to 105, and more than 106. So the size of the element depends upon the weight of the patient. I have already written it. You can see for 1 to 5 kg, size 1, 5 to 10, 1.5, 10 to 22, 20 to 32.5, 30 to 53, 50 to 74, 70 to 105, and more than 106. Now, size 3 is used for children and size 4 for adults. There can be a 50 kg adult or children, so size 3 is used for children and 4 for adults. Now, what are the contraindications of LMAs? Now, LMAs are contraindicated in 1. Full stomach patients. For example, pregnancy and tracheoesophageal fistula. Full stomach patients, for example, pregnancy and tracheoesophageal fistula. Second, patients with low pulmonary compliance. For example, morbidly obese patients. Patients with low pulmonary compliance, for example, morbidly obese patients. And third, patients with oral pathologies. Patients with oral pathologies. For example, Ludwig's angina, pharyngeal abscess, right? So, oral pathologies. Right? Right? Then comes the laryngoscopes. The next to come is laryngoscopes. Now, the laryngoscopes, most commonly type of laryngoscope comes with a curved blade, and this is known as Macintosh laryngoscope. This is known as Macintosh laryngoscope. Then there is another blade which comes with a straight blade. This is known as Miller's blade. This is known as Miller's blade. This is known as Miller's blade. Now, The laryngoscope is always held in the left hand. The laryngoscope is always held in the left hand, inserted from the right side of the mouth, and tongue displaced to left side. The laryngoscope is always held in the left hand, inserted from the right side of the mouth, and tongue displaced to left side. And tongue displaced to left side. Right? Now, the most common structures damaged during laryngoscopy are upper incisors. Most common structures damaged during laryngoscopy are upper incisors. They are upper incisors, most common structures. Now, what is the stress response to laryngoscopy? Stress response. It is hypertension, tachycardia, and arrhythmias. Stress response to laryngoscopy is hypertension, tachycardia, and arrhythmias. It is hypertension, tachycardia, and arrhythmias. This can be decreased by opioids like alfentanil or fentanyl, beta blockers like esmolol, calcium channel blockers like verapamil and lignocaine. These are the drugs which can be used to decrease the stress response to laryngoscopy. For example, alfentanil is better. Alfentanil and fentanyl, esmolol, verapamil, and lignocaine. Then, what is the position of laryngoscopy? What is the position of laryngoscopy? It is extension at the atlanto-occipital joint. I have already written the drugs here. Position of laryngoscopy. It is extension at the atlanto-occipital joint. Extension at atlanto-occipital joint and flexion in the neck. It is extension at atlanto-occipital joint. It is occipital joint and extension in the neck. So C1 and occiput के बीच में there is a extension and then there is a dorsiflexion like this. Right? Now, this is also known as sniffing position. This is also known as sniffing position. This is also known as sniffing position. Now, the sniffing position brings oral, pharyngeal, and laryngeal axis. The sniffing position brings oral, pharyngeal, and laryngeal axis. Oral, pharyngeal, and laryngeal axis in a straight line. It brings them in a straight line. So, you can view directly into the glottic opening. Oral, pharyngeal, and laryngeal axis in a straight line. Now, next is endotracheal tubes. Endotracheal tubes. Now, there are two types of endotracheal tubes, red rubber tube and PVC tube. There are two types of endotracheal tubes. Here opioid is L-fentanyl or fentanyl. L-fentanyl or fentanyl. Now, there are two types of endotracheal tubes, red rubber tubes and PVC tubes. Now, the red rubber tubes, what are the features of red rubber tubes? Features of red rubber tube. Now, the red rubber tubes are disposable, the red rubber tubes are reusable. Red rubber tubes are reusable, expensive, Murphy eye is absent. I will just tell you what is Murphy's eye. Murphy eye is absent. Murphy eye is absent. There is no Murphy's eye in the red rubber tube. Cuff is low volume, high pressure cuff. Cuff is low volume, high pressure cuff. Cuff is low volume, high pressure cuff. Now, since it is a high pressure cuff, these tubes are kept for less duration of time. They are kept for less duration. Since it is a high pressure cuff, they are used for less duration. They have higher chances of tracheal injury. Higher chances of injury. They have higher chances of tracheal injury. They have higher chances of tracheal injury. Right? Now, these tubes are non-transparent and radiolucent. These tubes are non-transparent and radiolucent. These tubes are non-transparent and radiolucent. Now, on the other hand, the PVC tubes are disposable, cheap. The PVC tubes are disposable, cheap. Murphy eye is present. Murphy eye is present. Now, what is Murphy's eye? I will just share with you a photograph. In this figure, you can see the upper figure. In the upper figure, this is the red rubber tube, and this is the PVC tube. Now, in the PVC tube, distal to the cuff is present a small hole. This hole is known as Murphy's eye. Right? There is no such hole in the red rubber tube. This hole is known as Murphy's eye. Now, what is the main function of Murphy's eye? What is the main function of Murphy's eye? Now, what happens is sometimes the bevel of the tube may get blocked by the tracheal wall. The bevel of the tube may get blocked by the tracheal wall. Then, due to the Murphy's eye, ventilation can be continued. Right? So, sometimes the bevel of the tube may get blocked by the tracheal wall. Then, due to the Murphy's eye, the ventilation can be continued. Now, then another point about the PVC tube is these tubes have high volume, low pressure cuff. These tubes have high volume, low pressure cuff. Now, since they have a low pressure cuff, they are used for longer duration and they have less chances of tracheal injury. These have less chances of tracheal injury because the pressure is low, so less chance of tracheal injury. Now, these tubes are transparent and radio opaque. These tubes are transparent and radio opaque. These tubes are transparent and radio opaque. Right? Now, the most common size of tube, these are the basic differences between the red rubber and the common points. Now, the most common size of tube used for adult male is 8 and 8.5, and for female 7.5 and 8. Most common size of tube used for adult male is 8 and 8.5 and 7.5 and 8 for female. The length of the tube which comes at upper incisor is 21 to 22 centimeter for males and 20 to 21 centimeter for females. The length of the tube which comes at upper incisors is 21 to 22 centimeter for males and 20 to 21 centimeter for females. Now the cuff of the tube should lie in mid trachea. The cuff of the tube should lie in mid trachea, 2 to 2.5 centimeters below the vocal cords. It should lie in mid trachea, 2 to 2.5 centimeters below the vocal cords. The cuff pressure should not exceed more than 30 centimeter of water or 20 millimeter of mercury. The cuff pressure should not exceed more than 30 centimeter of water or 20 millimeter of mercury. The cuff pressure should not exceed more than 30 centimeter of water or 20 millimeter of mercury. Right? Now, how will you confirm the presence of endotracheal tube in the trachea? How will you confirm the presence of tracheal tube into the trachea? One is by auscultation. And the most important area for auscultation is left base. The most important area for auscultation is left base, because the right bronchus is more straighter and broader. So the tube is likely to go on the right side. So therefore, for an equal entry, auscultation of left base is very important. So left base is the most important area for auscultation. Then second is rise and fall of chest. If the tube is in trachea, there will be rise and fall of chest due to positive pressure ventilation. Third is chest X-ray. You can see PVC tubes is radio opaque, so you can see them on chest X-ray. Fourth is capnography. This is the golden test for intubation. Fourth is capnography. This is the golden test for intubation. This is the golden test for intubation, capnography. Right? Now, what is capnography? Capnography is exhaled carbon dioxide. Capnography is exhaled carbon dioxide. Now, normal values are 35 to 45 millimeter of mercury. Normal values are 35 to 45 millimeter of mercury. Normal values are 35 to 45 millimeter of mercury. Now this is how the capnograph looks like. Right? This is how the capnograph looks like. This is the normal capnograph. Now, this is known as flat capnogram. Now, flat capnogram is that the capnograph was coming and then suddenly it becomes a flat line. Now, what are the conditions in which you can look for flat capnogram? Now, the flat capnogram is seen. 1. Esophageal intubation. Flat capnogram is seen in 1. Esophageal intubation. Second, disconnection of circuit. Third, cardiac arrest. Fourth, ventilatory failure. And fifth, accidental extubation. So these are the conditions in which you can see the flat capnogram, right? Now, this type of capnogram occurs in bronchospasm. This is also known as shark fin appearance. Then this occurs in endobronchial intubation. This type of capnogram occurs in endobronchial intubation. Right? Then a sudden fall in end-tidal carbon dioxide occurs in venous air embolism. And a sudden rise in end-tidal carbon dioxide occurs in malignant hyperthermia. A sudden rise in end-tidal carbon dioxide is malignant hyperthermia. A sudden fall in end-tidal carbon dioxide is venous air embolism. Then a central notch. This refers to requirement of muscle relaxant. A central notch refers to requirement of muscle relaxant. This refers to requirement of muscle relaxant. Right? Now, then next is endotracheal tubes in children. Now, in children, uncuffed tubes are used. Up till the age of 6 years. In children, uncuffed tubes are used up till the age of 6 years, because in children there are chances that there may be edema formation, and that edema can markedly reduce the airflow. So, uncuffed tubes are used up till the age of 6 years. Now, question is, how will you determine the size of tube in children? Now, for neonates it is 2.5 to 3, and for infants it is 3 to 3.5. Yeah, this is the only class. Right? In neonates it is 2.5 to 3, and in infants it is 3 to 3.5. This is the internal diameter of the tube, the numbers. Then for till I finish the course, the topics. Then for 1 to 6 years, it is age by 3 plus 3.5, and for 6 to 10 years, it is age by 4 plus 4.5. So this is how you will, for example, a 8-year-old child. In an 8-year-old child, it comes out to be 6.5. So this is how you will calculate the size of tube in children, right? Now, then next is the nasotracheal intubation. Nasotracheal intubation. Now, what about the nasotracheal intubation? What are the indications of nasotracheal intubation? The nasotracheal intubation is indicated in 1. Oral surgeries, fracture mandible, is the baby age is 3. So 1 to 3 years of age, it comes out to be 4.5. Now, indications for nasotracheal intubation are 1. Oral surgeries, fracture mandible, inadequate mouth opening due to any cause, right? Inadequate mouth opening. Then awake fiber optic intubation, and if tube is to be kept for longer duration of time, because the nasal tube is tolerated better than the agro. Fourth point is awake fiber optic intubation, and fifth is if tube is to be kept for longer duration of time, Now, contraindications to nasal intubation are fracture base of skull, contraindications to nasal intubation are fracture base of skull, then CSF rhinorrhea, nasal mass, adenoids, and coagulopathy. CSF rhinorrhea, adenoids, or coagulopathy. See, if you have to do a awake fiber optic intubation, then you can use the nasal airway. So the tube will be nasopharynx, to the nasopharynx. Agro, fifth point is if the patient has to be kept, the tube has to be kept for longer duration of time, then because the nasal tube is tolerated better. Contraindication, last point is coagulopathy. For example, low platelet count, high INR, any type of coagulopathy will come under contraindication for nasal intubation. Third point of indication, inadequate mouth opening. The mouth opening is not adequate size. यार आई एम नॉट टीचिंग यू फॉर 1 hour ना, सो आई कि मैं माइक पकड़ लूं अपने हाथ में. लंच ब्रेक तो अभी तो आए हैं आधे घंटा पहले. Right, so this basically finishes of the equipment part. So we'll start with IV anesthetic agents. IV anesthetic agents. Now, nasal intubation, you don't need any instrument. You can just put the tube and then you can use Magill forceps to guide the tube tip towards the glottic opening. Now, we'll start with IV anesthetic agents. Now, first of all, we'll start with thiopentone. First of all, we'll start with thiopentone. Now, just write down the main points about thiopentone. Main points of thiopentone. It was used for the first time in 1934. It was used for the first time in 1934. It is a yellow amorphous powder. It is a yellow amorphous powder which contains sodium carbonate. It is a yellow amorphous powder which contains sodium carbonate. It is prepared and stored in nitrogen atmosphere. It is prepared and stored in nitrogen atmosphere. Now, pH is 10.5 to 11. pH is 10.5 to 11. Should not be mixed with ringer lactate. Should not be mixed with ringer lactate. It will precipitate if you mix it with ringer lactate. Should not be mixed with ringer lactate. Dose is 3 to 5 milligram per kg body weight. Dose is 3 to 5 milligram per kg body weight. To 5 milligram per kg body weight. Adequate dose leads to loss of eyelash reflex. Adequate dose leads to loss of eyelash reflex. Adequate dose leads to loss of eyelash reflex. Then concentration used is 2.5%. Concentration used is 2.5%. Now, onset of action occurs within 30 seconds. Onset of action occurs within 30 seconds and lasts for 15 to 20 minutes. Onset of action occurs within 30 seconds and lasts for 15 to 20 minutes. So, it has got a very rapid onset along with short duration of action. Now, thiopentone acts upon the reticular activating system present in the brainstem. Thiopentone acts upon the reticular activating system present in the brainstem. Reticular activating system present in the brainstem. Then the patient regains consciousness from thiopentone anesthesia. The patient regains consciousness from thiopentone anesthesia by redistribution. The patient regains consciousness from thiopentone anesthesia by redistribution. by redistribution, right. So when the concentration, you give thiobenton, the concentration will rise in brain and the patient will lose the consciousness. When after some time the concentration will start falling in brain and will start rising in other tissues. So when the concentration falls in brain, the patient will regain the consciousness. This is known as redistribution. So the patient regains consciousness by redistribution and not by metabolism, right. Now the potency is due to the sulfur atom. The potency is due to the sulfur atom, which increases the lipid solubility. The potency is due to the sulfur atom, which increases the lipid solubility, right. The potency depends upon the lipid solubility, and in thiobenton, sulfur makes it very lipid soluble. Now, what are the systemic effects? In the cardiovascular system, it causes a fall in blood pressure plus increase in heart rate. In the cardiac system, it causes a fall in blood pressure and increase in heart rate. It also increases myocardial contractility. It also increases myocardial contractility. It also increases myocardial contractility. Then in the respiratory system, it causes apnea. In the respiratory system, it causes apnea. Treatment is IPPV, intermittent positive pressure ventilation. Treatment is IPPV, intermittent positive pressure ventilation. So it causes apnea. Treatment is IPPV, intermittent positive pressure ventilation. Then in the CNS, please remember, all IV anesthetic agents are cerebral vasoconstrictors. In the CNS, all IV anesthetic agents are cerebral vasoconstrictors except ketamine. All IV anesthetic agents are cerebral vasoconstrictors except ketamine. So when you cause cerebral vasoconstriction, what will happen? This will lead to decreased blood supply to the brain, and that will lead to decrease in ICP. It decreases ICP and it decreases cerebral metabolic rate. It decreases ICP and it decreases the cerebral metabolic rate. Now, since the cerebral metabolic rate is decreased, it provides cerebral protection. It provides cerebral protection. Since it decreases the cerebral metabolic rate, it provides the cerebral protection. Now, thiobenton is a powerful anticonvulsant agent. Thiobenton is a powerful anticonvulsant agent. It is a powerful anticonvulsant agent, and it is anti-analgesic. It is anti-analgesic. It lowers the threshold for pain, and it is anti-analgesic. It lowers the threshold for pain. It lowers the threshold for pain. It is anti-analgesic. Right? Now, thiobenton is a poor muscle relaxant. Thiobenton is a poor muscle relaxant. It does not provide muscle relaxation. It is a poor muscle relaxant. Now, what are the contraindications of thiobenton? What are the contraindications of thiobenton? It is contraindicated in 1. Acute intermittent porphyria and variegate porphyria. It is contraindicated in acute intermittent porphyria and variegate porphyria. It can be safely given in porphyria cuneata tarda. It can be safely given in porphyria cuneata tarda. It can be safely given in porphyria cuneata tarda. Right? This is the only one type of porphyria in which it can be given. Otherwise, it is contraindicated in other type of porphyrias. Right? Then thiopentone may show some anti-thyroid action. It may have some anti-thyroid action. Thiopentone may show some anti-thyroid action. Now, sometimes it is asked, what happens if there is an accidental intra-arterial injection? What happens if there is accidental intra-arterial injection? Right? What will happen at that time? Now, what will happen is, thiopentone has a very high pH. So, when it goes into the arterial circulation, which occurs most commonly in the antecubital fossa, right? It occurs most commonly in antecubital fossa. So, if it goes into the arterial circulation, it will, because of its high pH, it precipitates, and this precipitation leads to vasospasm of the artery. This will lead to vasospasm of the artery with loss of distal pulse. You will not be able to feel the pulse, loss of distal pulse, and whiteness and blanching of the hand. Loss of distal pulse and whiteness and blanching of the hand. Now, in such a scenario, the first step is, do not remove the needle. First step is, do not remove needle. Right? Do not remove needle. This is the first step, very important. This is the first step. Do not remove the needle. Then second, flush it with saline. Second, flush it with saline. Flush it with saline. Then third, give heparin to prevent thrombosis. Give heparin to prevent thrombosis. And fourth, give stellate ganglion block or brachial plexus block. Fourth, give stellate ganglion block or brachial plexus block. Right? Stellate ganglion block right? Give us stellate ganglion block or brachial plexus block for vasodilatation of the right. So, you can give stellate ganglion block or brachial plexus block. Stellate ganglion block will do what? It will cause vasodilatation of the upper limb vessels. So, the vessels become vasodilated, right. Then second drug is methotrexate. Then second drug is methotrexate. Now, methotrexate is also a short acting barbiturate. Methotrexate is also a short acting barbiturate. Now, in small doses, methotrexate causes convulsions. In small doses, methotrexate causes convulsions. In small doses, it causes convulsions, methotrexate. So as when you compare with thiopentone was anticonvulsant, but methoxytol is can cause convulsions, right? And third is etomidate. Etomidate. Now, etomidate is a milky white liquid. Etomidate is a milky white liquid it is a milky white liquid. It causes pain on injection. It causes pain on injection. Now, etomidate is most cardiostable induction agent. Etomidate is most cardiostable. Etomidate is most cardiostable induction agent. It is most cardiostable induction agent, etomidate. Then it causes highest incidence of nausea and vomiting. It causes highest incidence of nausea and vomiting. It causes highest incidence of myoclonic activity. It causes highest incidence of myoclonic activity. Causes highest incidence of myoclonic activity. And very importantly, etomidate causes adrenocortical suppression. Etomidate causes adrenocortical suppression and inhibit steroid synthesis. And inhibit steroid synthesis. And inhibit steroid synthesis. It causes adrenocortical suppression and inhibit steroid synthesis, leading to increase in mortality. Leading to increase in mortality. Now, vitamin C supplements are known to prevent adrenocortical suppression. Vitamin C supplements are known to prevent adrenocortical suppression. Then next is ketamine. Ketamine. Now, ketamine causes dissociative anesthesia. Ketamine causes dissociative anesthesia. Right? Sometimes the question is asked, which of the following causes dissociative anesthesia? It is ketamine. Now, the ketamine, it dissociates thalamic from the limbic system. Ketamine dissociates thalamic from the limbic system. It dissociates thalamic from the limbic system. The patient apparently remains conscious but unresponding. The patient apparently remains conscious but unresponding. You will feel that the patient is conscious but he will not respond to you. That is how the type of anesthesia occurs with ketamine. Patient apparently remains conscious but unresponding. Now, ketamine is metabolized to norketamine. Ketamine is metabolized to norketamine, NOR. Norketamine, NOR, norketamine. Ketamine is a phencyclidine derivative. Ketamine is a phencyclidine derivative. So, all the hallucinations and delirium seen with ketamine are due to phencyclidine. ketamine is a phencyclidine derivative. Now ketamine is strongly analgesic agent. It provides analgesia. Ketamine is strongly analgesic agent. It provides analgesia. It is strongly analgesic agent. It provides analgesia. Now what are the systemic effects? In the cardiovascular system, it causes increase in blood pressure plus increase in heart rate. In the cardiovascular system, it causes increase in blood pressure and heart rate. Causes increase in blood pressure and heart rate, and therefore it is drug of choice for shock patients, hypovolemic shock. And therefore it is drug of choice for hypovolemic shock patients. Therefore it is drug of choice for hypovolemic shock patients. Now, since it is causing an increase in blood pressure and heart rate, it should be avoided in or contraindicated in hypertensive patients, ischemic heart disease patients, and aortic aneurysm patients. Right? So it is contraindicated in hypertensive patients, ischemic heart disease patients, and aortic aneurysm patients, because it is causing an increase in heart rate and that will lead to increase in myocardial oxygen demand. So that's why it is contraindicated in hypertensive, ischemic heart disease, and aortic aneurysm patients. Now what happens in respiration? Now in respiration, it causes minimal respiratory depression. Minimal respiratory depression. It maintains upper airway reflexes. It maintains upper airway reflexes and is drug of choice for full stomach patients. It maintains upper airway reflexes and is drug of choice for full stomach patients. Now it is a potent bronchodilator. It is a potent bronchodilator and choice for asthmatic patients. It is a potent bronchodilator and choice for asthmatic patients. And choice for asthmatic patients because it is a potent bronchodilator. Now what happens in the CNS? Now in the CNS, it increases the ICP. In CNS, it increases ICP and is therefore contraindicated in head injury patients, space occupying lesions of the brain, head injury patients, space occupying lesions of the brain, for example any tumor, cyst, hematoma, and epilepsy patients. Head injury patients, space occupying lesions of the brain, and epilepsy patients. Now ketamine causes hallucinations. Ketamine causes hallucinations which occur more commonly in young patients. It causes hallucinations which occur more commonly in young patients. Children and older people have less incidence of hallucinations. Children and older people have less incidence of hallucinations. Now the hallucinations can be reduced by giving benzodiazepines. Hallucinations can be reduced by giving benzodiazepines. Hallucinations can be reduced by giving benzodiazepines. Now, ketamine causes increase in intraocular pressure. Ketamine causes increase in intraocular pressure and therefore it is contraindicated in glaucoma patients. And therefore it is contraindicated in glaucoma patients. Since it causes increase in intraocular pressure, So contraindicated in glaucoma patients, right? Now ketamine is the only agent which provides amnesia as well as analgesia. It does not provide muscle relaxation, but it is the only agent which provides you with amnesia as well as analgesia. So both these components are provided by ketamine. Now, then next is propofol. Next is propofol. Now, propofol is a milky white liquid which causes pain on injection. Propofol is a milky white liquid which causes pain on injection. The pain can be reduced. The pain can be reduced by mixing lignocaine with propofol. The pain can be reduced by mixing lignocaine with propofol. Right? Next, propofol contains soybean oil, glycerol and L-lecithin. Propofol contains soybean oil, glycerol and L-lecithin and is a good culture medium for bacterial growth. And is a good culture medium for bacterial growth. It contains soybean oil, glycerol and L-lecithin and is a good culture medium for bacterial growth. Now, open vial of propofol is discarded after 6 hours. Open vial of propofol is discarded after 6 hours. So, if you open the vial and you don't use it for 6 hours, you discard it. Right? Then propofol is associated with quick recovery. Propofol is associated with quick recovery and is therefore drug of choice for day care surgery. It is associated with quick recovery and is therefore drug of choice for day care surgery. And is therefore drug of choice for day care surgery. Now, what are the systemic effects? In the cardiovascular system, it causes a decrease in blood pressure plus bradycardia. In the cardiovascular system, it causes a decrease in blood pressure and bradycardia. Then in the respiration, it causes apnea. In respiration, it causes apnea. Now, it causes maximum depression of upper airway reflexes. It causes maximum depression of upper airway reflexes, and therefore it is drug of choice for LMA insertion. And therefore it is drug of choice for LMA insertion. Since it causes maximum depression of upper airway reflexes, it is drug of choice for LMA insertion. And the drug which maintains the upper airway reflexes is ketamine. So ketamine maintains and propofol causes maximum depression of upper airway reflexes. Then in the CNS, propofol is antiemetic, antipruritic, antioxidant and anticonvulsant. Now, in the CNS, it is antiemetic, antipruritic, antioxidant, and anticonvulsant. Right? So it is antiemetic, antipruritic, antioxidant, and anticonvulsant. Now, propofol, I have already told you, is associated with quick recovery and drug of choice for daycare surgery. Now, propofol is also drug of choice for porphyria patients. It is also drug of choice for porphyria patients. Now, propofol is also drug of choice for TIVA. Propofol is also drug of choice for TIVA. TIVA means total intravenous anesthesia. TIVA means total intravenous anesthesia. It is also a drug of choice for TIVA, total intravenous anesthesia. Then TIVA is a combination of propofol plus remifentanil. TIVA is a combination of propofol and remifentanil. This is basically a central effect, antipruritic. Basically what happens is when you give opioids they cause pruritus. So when you give a low dose of propofol, due to its central action, the patient will not complain of pruritus. So that's why it is antipruritic. So TIVA is a combination of propofol and remifentanil. Now propofol is associated with quick recovery, remifentanil is also associated with quick recovery, and therefore this is used for daycare surgery and for neurosurgery. This is used for daycare surgery and neurosurgery, right? Daycare surgery and neurosurgery. Now, myself, just 5 minutes more. Now, which are the drugs which produce active metabolites? So what are the drugs which produce active metabolites? These include thiopentone, methoxytol, and ketamine. Drugs producing active metabolites are thiopentone, methoxytol, and ketamine. And drugs producing inactive metabolites are propofol and etomidate. Drugs producing inactive metabolites are propofol and etomidate. Right? Take a lunch break, but lunch break will not be more than half an hour because I have to complete the course. So it is 1:50. So we start at 2:20 again. Ketamine and inactive metabolites are produced by etomidate and propofol. Active metabolites are produced by thiopentone, ketamine, and methoxytol. Right. So now we'll start with inhalational agents. Right. and the first inhalational agent is ether. First inhalation agent is ether. Now, what are the most important points about ether? Now, right? Now, but I will just tell you afterwards, right? Now, ether is pungent smelling and decomposes in presence of light. Ether is pungent smelling and decomposes in presence of light. It is stored in amber colored bottles. Stored in amber colored bottles. Ether is flammable and highly explosive. Ether is flammable and highly explosive and therefore contraindicated with cautery. It is flammable and highly explosive and therefore contraindicated with cautery. Now, ether causes lot of secretions and therefore has high incidence of laryngospasm. It has lot of secretions and therefore have high incidence of laryngospasm. Ether is a potent bronchodilator. It is a potent bronchodilator. Ether is the only agent which does not depress the ciliary activity. It is the only agent which preserves ciliary activity. It is the only agent which preserves the ciliary activity. It does not depress the ciliary activity. It is the only agent which does that. Right? Now, ether is very cardiostable. It does not cause respiratory or cardiac depression. It is very cardiostable. It does not cause respiratory or cardiac depression. Right? Then there is one thing which is associated with ether, which is known as ethyromania. What is ethyromania? E-T-H-E-R. Ethyromania. Ethyromania means addiction or dependence of ether. Ethyromania means addiction or dependence of ether. Ethyromania, addiction or dependence of ether. Right? Then second agent is methoxyflurane. Second agent is methoxyflurane. Now, what about methoxyflurane? Methoxyflurane is most potent inhalational agent. Methoxyflurane is most potent inhalational agent. It causes vasopressin resistant high output renal failure. It causes vasopressin resistant high output renal failure. It is hepatotoxic. It is hepatotoxic. It has got highest boiling point among inhalational agent. It has highest boiling point. It has highest boiling point among inhalational agent. It has highest boiling point among inhalational agent. Highest boiling point among inhalational agent. Right? Methoxyflurane. Then comes trilene. Now, trilene, then comes trilene. Now, trilene is most potent analgesic agent. Most potent analgesic agent. It is most potent analgesic agent. It reacts with soda lime. It reacts with soda lime. It reacts with soda lime, trilene. Then next is cyclopropane. Cyclopropane. Now cyclopropane, it comes in orange color cylinders. Cyclopropane comes in orange color cylinders. It causes sympathetic stimulation. It causes sympathetic stimulation leading to increase in blood pressure and heart rate. It causes sympathetic stimulation leading to increase in blood pressure and heart rate. Right? Then comes chloroform. Chloroform. Now chloroform was first used in 1847. It was first used in 1847. It is very toxic. It is very toxic and it causes ventricular fibrillation leading to sudden death. It is very toxic and it causes ventricular fibrillation leading to sudden death. It causes profound hyperglycemia. It causes profound hyperglycemia and therefore should be avoided in diabetic patients. It causes profound hyperglycemia and therefore should be avoided in diabetic patients. Right? Now, then next to come is nitrous oxide. Next to come is nitrous oxide. Now, nitrous oxide is prepared by heating ammonium nitrate. It is prepared by heating ammonium nitrate at 250 degree centigrade. At 250 degree centigrade. Now, nitrous oxide is a colorless, odorless gas. It is a colorless, odorless gas. It is 1.5 times heavier than air and 35 times more soluble than nitrogen. It is 1.5 times heavier than air and 35 times more soluble than nitrogen. 35 times more soluble than nitrogen. Now, what are the systemic effects? In the cardiovascular system, it increases the pulmonary vascular resistance. In the cardiovascular system, it increases the pulmonary vascular resistance, leading to, right, and therefore contraindicated in pulmonary hypertensive patients. In the cardiovascular system, it increases the pulmonary vascular resistance and therefore it is contraindicated in pulmonary hypertensive patients. In the respiratory system, it inhibits carotid body hypoxic drive. In the respiratory system, it inhibits carotid body hypoxic drive, while in the CNS, it increases ICP and cerebral metabolic rate. In the CNS, it increases ICP and cerebral metabolic rate, and it provides analgesia. And it provides analgesia. it does not affect CSF secretion or absorption. It does not affect CSF secretion or absorption. Does not affect CSF secretion or absorption. Right? Then, what about the toxicity of nitrous oxide? Toxicity of nitrous oxide. Now, nitrous oxide, if continued for more than 6 hours, irreversibly oxidizes cobalt atom of vitamin B12. It irreversibly oxidizes cobalt atom of vitamin B12 and causes cobalt atom of vitamin B12 and causes inhibition of enzymes methionine synthetase and thymidylate synthetase. It causes inhibition of enzymes methionine synthetase and thymidylate synthetase. Now, inhibition of these enzymes leads to bone marrow depression, or megaloblastic anemia. Inhibition of these enzymes leads to bone marrow depression or megaloblastic anemia, peripheral neuropathy, and pernicious anemia. It leads to bone marrow depression or megaloblastic anemia, peripheral neuropathy, and pernicious anemia. So, it leads to bone marrow depression or megaloblastic anemia, peripheral neuropathy, and pernicious anemia. Now, nitrous oxide also has a tendency to expand any air containing cavity. Nitrous oxide also has a tendency to expand any air containing cavity. Nitrous oxide also has a tendency to expand megaloblastic anemia. It also has a tendency to expand any air containing cavity, and therefore it is contraindicated in 1, venous air embolism. What happens in venous air embolism? If there is a venous air embolism and you are giving nitrous oxide, it will increase the size of the embolus. Then, second, pneumothorax. Third, lung bulla. Fourth, intracranial surgeries, especially posterior fossa surgery. Intracranial surgery, especially posterior fossa surgery, because posterior fossa is a small space present at the back of the head and it is a bony space, and in bony space the volume will not increase, the pressure increases, and that can lead to cardiac and respiratory arrest. Then, so contraindications include venous air embolism, pneumothorax, lung bull layer cyst, intracranial surgeries, especially posterior fossa surgery. Then vitreoretinal surgeries. Then tympanoplasty and acute volvulus. Fifth is vitreoretinal surgeries. Then tympanoplasty and then acute volvulus. Right? Now, then there are two things which are associated with nitrous oxide. One is the concentration effect. Concentration effect. Now, what is concentration effect? What happens is, if this is an alveoli and this is the blood vessel, Schneider fifth is vitreoretinal surgeries, vitreoretinal eye surgery. Now what happens is, in concentration effect, the nitrous oxide will come into the alveoli, and since it is 35 times more soluble, it gets rapidly absorbed into the blood. This allows more nitrous oxide to come in, and this is known as concentration effect. Rapid uptake of nitrous oxide into the blood, allows more nitrous oxide to come, thus shortening the induction time. Now this allows the inhalational agents like halothane, desperin also to come faster, and that is known as second gas effect. So not only nitrous oxide increases its own effect, own concentration, but also increases concentration of other inhalational agents, and that is known as second gas effect. So sometimes the question is asked, second gas effect is seen with, concentration effect is seen with, it is seen with nitrous oxide. Now, Bhatinda, you asked me about the propofol infusion syndrome. Before I move further, I will just tell you what is propofol infusion syndrome. It is a triad of metabolic acidosis, skeletal myopathy, and acute cardiomyopathy. It is a triad of metabolic acidosis, skeletal myopathy, and acute cardiomyopathy. There are three things which are associated with it. Right? Now, so propofol infusion syndrome is a triad of metabolic acidosis, skeletal myopathy, and acute cardiomyopathy. Name of, right? Propofol infusion syndrome. Now, it is seen in children on prolonged infusion. It is seen in children on prolonged infusion due to failure of metabolism of free fatty acids. It is seen in children on prolonged infusion due to failure of metabolism of free fatty acids. Right? It carries a higher mortality rate. It carries a high mortality rate. Now, we'll start with failure of metabolism of free fatty acids. Oh, yeah, this is not working. Right. So we will start with fluorinated inhalational agents, and the first fluorinated inhalational agent is halothane. The first fluorinated inhalational agent is halothane. Now, halothane is structurally different from all other inhalational agents. Why? Because all of them are ethers, while halothane is an alkane. Halothane is alkane. All of them are ethers, while halothane is an alkane. Topic is fluorinated inhalational agents or modern inhalational agents. And first one is halothane. Now, I was telling you that halothane is not a ether, it is an alkane, right? So, if the question comes which of the following is not a ether, answer is halothane. Halothane is alkane. Now, halothane is the only agent which contains bromine atoms. Halothane is the only agent which contains bromine atoms, right? No other inhalational agent has bromine atoms. Halothane is the only one which contains bromine atoms. Now, halothane is absorbed in rubber tubings. Halothane is absorbed in rubber tubings but less than methoxyfluorine. Halothane is absorbed in rubber tubings but less than methoxyfluorine. Then halothane, it reacts with metals in vaporizers. Halothane reacts with metals in vaporizers in the presence of moisture. It reacts with metals in vaporizers in the presence of moisture. Absorbed in metals. It reacts with metals in vaporizers in the presence of moisture. 1 minute. Huh? Now, it is absorbed in rubber tubings. It is absorbed in rubber tubings. It reacts with metals in vaporizers and it is absorbed in rubber tubings, but less than methoxyfluorine. But less than methoxyfluorine. Now, what are the systemic effects? In the cardiovascular system, absorbed in rubber tubings. Now, in the cardiovascular system, it causes a fall in blood pressure plus bradycardia. It causes a fall in blood pressure with bradycardia. It also makes heart sensitive to catecholamines. It also makes heart sensitive to catecholamines. It also makes heart sensitive to catecholamines. So if you give adrenaline containing compounds with halothane, it causes arrhythmias. If you give adrenaline containing compounds with halothane, it causes arrhythmias. It causes arrhythmias if adrenaline containing compounds are given with halothane. Now, right? Then in the respiratory system, it is a potent bronchodilator. It is a potent bronchodilator. It is a potent bronchodilator and drug of choice for asthmatic patients. And drug of choice for asthmatic patients. It is a potent bronchodilator and drug of choice for asthmatic patients. Then it causes severe depression of hypoxic ventilatory drive. It causes severe depression of hypoxic ventilatory drive. Severe depression of hypoxic ventilatory drive. Then what happens in the CNS? Now in the CNS, it increases the ICP. It increases the ICP, right? In the CNS, it increases ICP. It does not provide any analgesia. It does not provide any analgesia. Halothane causes shivering, known as halothane shakes. Halothane causes shivering, known as halothane shakes. It causes shivering, known as halothane shakes. Now the drug of choice for shivering is pethidine. Drug of choice for shivering is pethidine. Now, halothane is a central effect है shivering का. Now, halothane is a potent uterine relaxant. It is a potent uterine relaxant and drug of choice for manual removal of placenta. It is a potent uterine relaxant and drug of choice for manual removal of placenta. Agra or any place, please, जो चल रहा है वही, I am not going to repeat it again and again because it becomes difficult to with so many centers. So I cannot repeat it. We'll see in the break. Now, So it is a potent uterine relaxant and it is drug of choice for manual removal of placenta. Now, halothane causes maximum decrease in total hepatic blood flow and portal vein flow. It causes maximum decrease in total hepatic blood flow and portal vein flow. So it maximally decreases again this question has been asked many times, which of the following causes maximum decrease in total hepatic blood flow? It is halothane. Now halothane, of all the agents, halothane is maximally metabolized. More than 20% is metabolized. More than 20% is metabolized. Yeah, it is chlorinated. Halothane is chlorofluorobromo, right? So halothane is more than 20%, metabolized. So of all the agents, it is the one which has got the maximum metabolism, and that is this halothane. Now halothane, it is metabolized to trifluoroacetic acid. It is metabolized to trifluoroacetic acid, and this trifluoroacetic acid can cause an autoimmune response leading to hepatitis. This can cause an autoimmune response leading to hepatitis, right? So hepatitis is rare but seen with halothane, and it is very it has got a very high mortality rate. Mortality rate is 50 to 70%. Pathology is centrilobular necrosis. Now, the agent of choice in case of halothane hepatitis, agent of choice is sevoflurane. So if the patient has a history of halothane hepatitis, which agent can be safely given? It is sevoflurane, right? If the patient has a history of hepatitis with halothane, then you can safely give sevoflurane. That is the agent of choice. Now, as with all other inhalational agents, halothane is a triggering factor for malignant hyperthermia. As with other agents, halothane is a triggering factor for malignant hyperthermia. So it also causes malignant hyperthermia, right? Now, second drug to come is enflurane. Second drug to come is enflurane. Now, what about enflurane? It also makes heart sensitive to catecholamines. Enflurane also makes heart sensitive to catecholamines. Just like halothane, it also makes heart sensitive to catecholamines. Enflurane can cause tonic and clonic seizures. Enflurane can cause tonic and clonic seizures. So contraindicated in epilepsy patients. It can cause tonic and clonic seizures. So contraindicated in epilepsy patients. So enflurane causes tonic and clonic seizures, so contraindicated in epilepsy patients. Then third, it mildly reduces renal concentrating ability. It mildly reduces renal concentrating ability. So contraindicated in pre-existing renal diseases. So contraindicated in pre-existing renal diseases. Now, as with other agents, it mildly decreases renal concentrating ability. Now, as with other agents, it is also a triggering factor for malignant hyperthermia. As with other agents, it is also a triggering factor for malignant hyperthermia. Now, then comes isoflurane. Malignant hyperthermia occurs because of the abnormality of ryanodine receptor, which when a triggering agent is given, this ryanodine receptor causes massive release of calcium from sarcoplasmic reticulum. And this massive release of calcium then leads to sustained contraction of the muscle, which leads to a rapid rise in temperature and other problems. Now, what about isoflurane? Isoflurane is a chemical isomer of enflurane. It is a chemical isomer of enflurane. It is pungent smelling. It is pungent smelling. Now, isoflurane, it causes a fall in blood pressure with tachycardia. It causes fall in blood pressure with tachycardia. It causes fall in blood pressure with tachycardia. It is drug of choice. It is drug of choice for deliberate hypotensive anesthesia. It is drug of choice for deliberate hypotensive anesthesia. It is drug of choice for deliberate hypotensive anesthesia. Now, right? It is also drug of choice. It is a powerful coronary artery vasodilator. It is a powerful coronary artery vasodilator. It is a powerful coronary artery vasodilator and is agent of choice for cardiac surgery in patients with good left ventricular function. In patients with good left ventricular function. Choice for cardiac surgery in patients with good left ventricular function. If the patient has poor left ventricular function, choice is opioids. In patients with poor left ventricular function, choice is opioids. In patients with good left ventricular function, the choice is isoflurane. Now, then it may be sometimes, isoflurane may be sometimes associated with coronary steal syndrome. It may be sometimes associated with coronary steal syndrome. Then in the CNS, it increases ICP, which can be decreased by hyperventilation. which can be decreased by hyperventilation. It increases ICP which can be decreased by hyperventilation. No, I don't cover opioids. Which can be decreased by hyperventilation. Now, it causes isoelectric EEG. It causes isoelectric EEG at 2 Mach. It causes isoelectric EEG at 2 Mach. So, twice the Mach value, it causes isoelectric EEG. Now, Srinagar, hypotensive anesthesia is practiced in neurosurgery, right? It is basically practiced in neurosurgery. Isoelectric EEG at 2 Mach. I also don't know when the class will get over. Let's see. Because after inhalation agents there are muscle relaxants, again depolarizing and non-depolarizing. Then there are local anesthetics. Then there is spinal anesthesia and there is CPR. So at least these are the topics which have to be covered. So let's see how much time it takes. I also don't know. Now, then again it is a triggering factor for malignant hyperthermia. Isoflurane is a triggering factor for malignant hyperthermia. The next is desflurane. Yeah, all anesthesia will cover today. Desflurane. Now, desflurane is very pungent smelling. It has lowest blood gas coefficient, very pungent smelling, lowest blood gas coefficient, it is very pungent smelling, lowest blood gas coefficient. Then it causes sympathetic stimulation on high concentrations. It causes sympathetic stimulation on high concentration, leading to increase in blood pressure and heart rate. It causes sympathetic stimulation on high concentrations, leading to increase in blood pressure and heart rate. Then it causes airway irritation. It causes airway irritation. It causes airway irritation, that is breath holding, coughing, laryngospasm, breath holding, coughing, laryngospasm, and salivation. Now, desflurane is minimally metabolized in the body. It is only metabolized less than 0.2%. Desflurane is minimally metabolized in the body. It is metabolized only less than 0.2%. So, when you compare it with halothane, which was more than 20%, this is only 0.2% which is metabolized. Now, desflurane, it reacts with beryllium. Desflurane, it reacts with beryllium to form harmful levels of carbon monoxide. Desflurane, it reacts with beryllium to form harmful levels of carbon monoxide. Harmful levels of carbon monoxide. Now, desperine has a very high vapor pressure. Desperine has a very high vapor pressure, and therefore it requires a special vaporizer. CO is carbon monoxide. Desperine has a very high vapor pressure, and therefore it requires a special vaporizer. The desperine vaporizer is heated. The desperine vaporizer is heated to a temperature of 39 degrees centigrade. The desperine vaporizer is heated to a temperature of 39 degree centigrade. So sometimes they will ask you a question ki which of the following vaporizer is heated. It is desperine, and desperine vaporizer is heated to a temperature of 39 degree centigrade. Now then next is sevoflurane. Now, sevoflurane is maximally fluorinated agent. It has got the highest number of fluorine atoms. Sevoflurane is maximally fluorinated agent. It is maximally fluorinated agent, highest number of fluorine atoms. It has got a low blood gas coefficient. .65. It has low blood gas coefficient 0.65, and therefore it has a rapid recovery. Therefore has a rapid recovery. Now sevoflurane is it is associated with rapid recovery. Now it is mildly sweet smelling. 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 And sevoflurane is agent of choice. It is agent of choice for daycare surgery and inhalational induction in children. It is agent of choice for daycare surgery and inhalational induction in children, right? So it is used for both these purpose. Now it prolongs QT interval on ECG. It can prolongs QT interval on ECG. Prolongs QT interval on ECG, and it causes minimal cerebral vasodilatation. Minimum cerebral vasodilatation. So no increase in ICP. It causes minimal cerebral vasodilatation and no increase in ICP, and therefore it is drug of choice. And therefore it is drug of choice for neurosurgery. And therefore it is drug of choice for neurosurgery, because it does not cause any increase in ICP. Now I have already told you in the morning Sevoflurane, it reacts with soda lime to form compound A. Sevoflurane, it reacts with soda lime to form compound A, and compound A is nephrotoxic. Compound A is nephrotoxic. A minimum fresh gas flow rate of 2 liters per minute. A minimum fresh gas flow rate of 2 liters per minute should be used to prevent formation of compound A. A minimum fresh gas flow rate of 2 liters per minute should be used to prevent formation of compound A. Right? Then last is xenon. Now, xenon is a weak anesthetic but more potent than nitrous oxide. It is more potent than nitrous oxide. It is a weak anesthetic but more potent than nitrous oxide. It is agent of choice for liver disease patient. It is agent of choice for liver disease patients. It is most closest to ideal anesthetic agent. It is most closest to ideal anesthetic agent. It is most closest to ideal anesthetic agent. It has rapid induction and rapid recovery and lowest blood gas coefficient. Lowest blood gas coefficient कितना होता है 0.16. It has lowest blood gas coefficient 0.16. It has lowest blood gas coefficient 0.16. Right? Problems with xenon anesthesia are: 1. It is only present in very small amounts. Problems with xenon anesthesia are: 1. It is only present in very small amounts, and secondly, no viable anesthesia machine to provide xenon anesthesia. Only present in small amounts, so it is very expensive, and no viable anesthesia machine to provide xenon anesthesia. Okay, this basically finishes off the inhalation agents. So we will now start with muscle relaxants. I was giving you some muscle relaxation because I also know that your hands are little bit tired, right? Okay, we'll start with the muscle relaxant. So you can divide the muscle relaxants in two groups. Basically, you can divide them one into the centrally acting and peripherally acting. The muscle relaxants which we use in anesthesia, they act upon the neuromuscular junction. That is, they are peripherally acting muscle relaxants. They are not centrally acting muscle relaxants. They are peripherally acting muscle relaxants, and they act upon the neuromuscular junction. Sometimes the question is asked, where does they act upon? They act upon the neuromuscular junction. Now you can divide them into two groups, depolarizing and non-depolarizing. Depolarizing only has one drug, that is succinylcholine, while non-depolarizing again can be divided into benzyl isoquinonium and aminosteroids, right? So you can divide them into again two, benzyl isoquinonium and aminosteroids. So we'll starting with first with the succinylcholine. Now, what are the features of succinylcholine block? Now, succinylcholine causes sustained depolarization of the receptors. Succinylcholine causes sustained depolarization of the receptors, right? Then next, succinylcholine causes fasciculations. Next, succinylcholine is not reversed by anticholinestrases. For example, neostigmine, atrophonium, pyridostigmine, they are not used for succinylcholine reversal. So it is not reversed by anticholinestrases. Fourth, succinylcholine do not show any fade. Succinylcholine does not show fade. Right? I will just tell you what is fade. It does not show any fade. Now, it is antagonized by acidosis and non-depolarizing muscle relaxants. Now, the dose of succinylcholine is 2 mg per kg body weight. And if succinylcholine is given more than 5 mg per kg body weight, if succinylcholine is given more than 5 mg per kg body weight, it causes conformational changes in receptors. And the block starts behaving like a non-depolarizing block. Known as phase 2 blockade. So sometimes question is asked, at which dose phase 2 block occurs? It occurs at 5 mg per kg body weight. Now, Dibugard, it is antagonized by acidosis and non-depolarizing muscle relaxants. Now, The onset time of succinylcholine is within 30 seconds. That means it is very fast acting. The onset time is within 30 seconds and lasts for 10 to 12 minutes. Now, because of this very rapid onset, it is drug of choice for full stomach patients. Because of its very rapid onset, it is drug of choice for full stomach patients. Now, succinylcholine causes bradycardia, especially in children. Succinylcholine causes bradycardia, especially in children after second dose. Succinylcholine causes bradycardia, especially in children after second dose. Now, succinylcholine causes increase in pressures. ICP, blood pressure, gastric pressure, intraocular pressure, all the pressures are increased. Succinylcholine causes increase in pressures, intracranial pressure, intraocular pressure, blood pressure, gastric pressure. All the pressures are increased by succinylcholine. So, it causes an increase in pressures. Now, succinylcholine is metabolized by plasma pseudocholinesterase. It is metabolized by plasma pseudocholinesterase. Now, genetic absence of plasma pseudocholinesterase, if the enzyme is genetically absent, this will lead to increased duration of succinylcholine. Genetic absence of plasma pseudocholinesterase leads to increased duration of succinylcholine, known as choline apnea. Known as choline apnea. Treatment is IPPV and fresh frozen plasma. Treatment is IPPV and fresh frozen plasma. Right? Choline apnea, SCOLINE, choline apnea. Treatment is IPPV and fresh frozen plasma, intermittent positive pressure ventilation and fresh frozen plasma. Now, which patient has genetic absence and which patient does not have? For this there is a test, and that test is known as Deboucaine number. That test is known as Deboucaine number. Now, what is Deboucaine number? It is percentage inhibition of plasma cholinesterase. It is percentage inhibition of plasma cholinesterase by Deboucaine. What is Deboucaine number? It is percentage inhibition of plasma cholinesterase by Deboucaine. Normally it blocks 75 to 85% of enzyme. Normally it blocks 75 to 85% of enzyme, but in deficient patients it only blocks 30%. Normally it blocks 75 to 85% of enzyme, but in deficient patients it only blocks 30%. In deficient patients it only blocks 30%. Now, next point. Now, succinylcholine is contraindicated in muscular dystrophies. Succinylcholine is contraindicated in muscular dystrophies. In dystrophica myotonica it causes, in dystrophica myotonica it causes severe muscle rigidity, preventing respiration and intubation. In dystrophica myotonica it causes severe muscle rigidity, preventing respiration and intubation. Now, Succinylcholine increases potassium levels by 0.5 millimole per liter. It increases potassium levels by 0.5 millimole per liter, and the increase is more after burns, spinal cord injury, stroke, and cerebral palsy. Basically neuromuscular orders. It causes an increase in potassium by 0.5 millimoles per liter, and the increase is more after burns, spinal cord injury, stroke, and cerebral palsy. In these, preventing respiration and intubation. Right? Now, succinylcholine is the most common drug implicated for malignant hyperthermia. Succinylcholine is the most common drug implicated for malignant hyperthermia. Most common drug implicated for malignant hyperthermia. Now, succinylcholine causes post-operative myalgias or muscular pains. It causes post-operative myalgias. Succinylcholine causes post-operative myalgias. Now, why does post-operative myalgias or post-operative muscular pain occurs? Because of fasciculations, and these fasciculations can be decreased by giving a small dose of non-depressing muscle relaxant, and these fasciculations can be decreased by giving a small dose of non-depressing muscle relaxants. Now, succinylcholine causes post-operative myalgias which occur due to fasciculations, and fasciculations can be reduced by giving a small dose of non-depolarizing muscle relaxant. Now, succinylcholine causes histamine release. Succinylcholine causes histamine release and stimulates ganglionic blockade and causes ganglionic stimulation right. So all these are the points. Actually these are not the points, all these have been asked as questions from succinylcholine. So very common topic from which the questions are asked. Now, then comes the neuromuscular monitoring. Now, the most common nerve used for neuromuscular monitoring is ulnar nerve, and the most common muscle used for neuromuscular monitoring is adductor pollicis muscle. The most common nerve is ulnar nerve, and the most common muscle is adductor pollicis muscle. Right? Now, the most common mode used for neuromuscular monitoring is TOF. TOF means train of 4. What happens in TOF? In TOF, 4 stimulus are given at an interval of 0.5 seconds, and each stimulus has a frequency of 2 Hz. Each stimulus has a frequency of 2 Hz, and 4 stimulus are given at each one with a time interval of 0.5 seconds. Now, the TOF is measured every 10 to 20 seconds. the TOF is measured every 10 to 20 seconds. Now, what happens to TOF normal muscle? Now, when the TOF is applied to a normal muscle in which you don't give any muscle relaxant, you get stimulation, and all these stimulus are equal in size. You can see the height of each stimulus is equal, right? What happens with succinylcholine? With succinylcholine, again, all the stimulus are equal in size, but height is markedly decreased. All the stimulus are equal in size, but they are markedly decreased. What happens with non-depolarizing muscle relaxants? Again, you can see with non-depolarizing muscle relaxants, the first stimulus has a greater height, and then the height keeps on decreasing. Now, this decrease in the height is known as fade. So, fade is something which is only seen with non-depolarizing muscle relaxants. It is not seen with succinylcholine. So, sometimes question is asked, fade is not seen with. Fade is not seen with succinylcholine. It is only seen with non-depolarizing muscle relaxants. Right? Now, the golden standard for neuromuscular monitoring is electromyography. The golden standard for neuromuscular monitoring is electromyography. Now, next to come is non-depolarizing muscle relaxants. Next to come is non-depolarizing muscle relaxants. Now, what about non-depolarizing muscle relaxants? They show fade. They are reversed by neostigmine. They show fade. They are reversed by neostigmine. Right? Now, I told you in the beginning that the non-depolarizing muscle relaxants, they can be divided into two groups. One is benzyl isoclonium, another is amino steroids. Now, first benzyl isoclonium. And the first benzyl isoclonium is atracurium. First isoclonium is atracurium. Now, what about the main points about atracurium? Main points about atracurium. 1. It is metabolized by 75% by, it is metabolized 75% by Hoffman degradation and 25% by alkaline ester hydrolysis. It is metabolized 75% by Hoffman degradation and 25% by alkaline ester hydrolysis. 25% by alkaline ester hydrolysis. So 75% by Hofmann degradation and 25% by alkaline ester hydrolysis. The dose is given according to the total body weight. Dose is given according to the total body weight. It produces a metabolite known as lodonosine. It produces metabolite known as lodonosine, and this lodonosine can cause convulsions. It produces metabolite known as lodonosine, and lodonosine can cause convulsions. It produces metabolite known as lodonosine, and lodonosine can cause convulsions, right? Now, since atracurium is neither metabolized by kidneys nor by the liver, it is drug of choice for renal failure patients, hepatic failure patients. Since it is neither metabolized by kidneys nor liver, it is drug of choice for renal failure patients, hepatic failure patients, patients with atypical pseudocholesterase, and in patients with myasthenia gravis. Now, in myasthenia gravis, 1/10 of the normal dose is used. In myasthenia gravis, 1/10 of the normal dose is used. Now, atracurium causes histamine release. Atracurium causes histamine release. Then next is cis-atracurium. 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 Now, cis-atracurium do not release any histamine. It is metabolized 100% by Hofmann degradation. Lodonosine levels are lower. And it do not release any histamine. It does not release any histamine. So the basic difference between cis-atra and atra is it do not release any histamine. Now, if you get a question in which you have both the alternatives, then the answer will be cis-atracurium. If they ask you in renal failure which should be preferred, cis-atracurium or atracurium, then the answer will be cis-atracurium because of its lesser side effects. Now, then the next drug is mevacurium. Now, mevacurium has short duration but slow onset. Mevacurium has short duration but slow onset. It causes histamine release. Then DTC, D-tuberculin. D-tuberculin. Right? Now D-tuberculin, it causes maximum histamine release, and it causes ganglionic blockade. Leading to fall in blood pressure. It causes maximum histamine release and causes ganglionic blockade, leading to fall in blood pressure. Then comes aminosteroids. And the first aminosteroid is vecuronium. Now vecuronium has intermediate duration of action. Undergoes hepatic metabolism. Most cardiostable muscle relaxant. Then second is pancuronium. Now pancuronium is long acting, mainly undergoes renal metabolism. Causes sympathetic stimulation, leading to increase in blood pressure and heart rate. Pancuronium. And third is rocuronium. Now rocuronium is intermediate acting. It has most rapid onset among NDMR. It is NDMR of choice. For full stomach patients. Now rocuronium causes pain on injection. Then fourth is rapacuronium. Rapacuronium. Now, once the muscle relaxants finish off now, then you will get their muscular break. Now, rapacuronium, it also has rapid onset of action. But causes high incidence of bronchospasm. In children and therefore withdrawn. Dibugard, drug of choice for full stomach patient. Muscle relaxant of choice for full stomach patient is succinylcholine. Wherever succinylcholine cannot be given, is contraindicated, the choice becomes rocuronium. If the question is asked what is the non-deplazing muscle relaxant of choice, the answer will be rocuronium. If it is asked drug of choice, answer will be succinylcholine. But you have to also see that there is no contraindication to succinylcholine. right? Then comes after epacronium galamine. Galamine. Now, galamine is the only muscle relaxant which crosses placenta, so contraindicated in pregnancy. So contraindicated in pregnancy. It is the only muscle relaxant which crosses placenta. Now, it is metabolized 100% by kidneys. It is metabolized 100% by kidneys. So, contraindicated in renal diseases. So, contraindicated in renal diseases. Then comes metocurine. Now, metocurine is also metabolized 100% by kidneys. Metocurine is also metabolized 100% by kidneys. Now, metocurine, it contains iodine. Metocurine contains iodine, so contraindicated in iodine sensitivity patients. Metocurine contains iodine, so contraindicated in iodine sensitivity patients. And last is gantacurium. It is ultra short acting muscle relaxant. Gantacurium is ultra short acting muscle relaxant. Gantacurium, ultra short acting muscle relaxant. Then I am just giving you break, just another 5 minutes. Now, then comes reversal of muscle relaxation. Reversal of muscle relaxants. Now, neostigmine is used for reversal of muscle relaxation. Neostigmine is used for reversal of muscle relaxation. Now, neostigmine does not cross the blood-brain barrier. Neostigmine does not cross blood-brain barrier, but it has certain side effects. It has certain side effects. What are side effects? These include bradycardia, bronchospasm, increased salivary secretions, increased bladder tone, meiosis, and increased peristalsis. Right? So, these are the side effects associated with neostigmine: bradycardia, bronchospasm, increased salivary secretions, increased bladder tone, meiosis, and increased peristalsis. Now, of these, bradycardia is most dangerous. So, neostigmine is always combined with atropine or glycopyrrolate. Neostigmine is always combined with atropine or glycopyrrolate. What is the best sign of reversal? It is sustained head lift for more than 5 seconds. This is the best sign of reversal. Sustained head lift for more than 5 seconds. This is the best sign of reversal. sustained head lift for more than 5 seconds, right? Take a 10, okay, take a 10-12 minute break and then we will start with the rest of the part. How much are left for today's class? Local anesthetics, spinal anesthesia and CPR. 2 hours. Right? So let's see. So we'll start with local anesthetics. Now, there are 3 types of fibers, A, B and C. A are the largest fibers while C are the smallest fibers. A and B are myelinated while C fibers are non-myelinated. Now, A and B are myelinated, C are non-myelinated. Now, the A fibers, they basically mediate motor and muscle tone. B fibers are autonomic preganglionic fibers and C fibers are autonomic postganglionic fibers. Now, the B fibers, they mediate the autonomic nervous system and C fibers mediate temperature, pain, touch and pressure. Now, what is the sensitivity of these fibers to local anesthetic agents? It is B, C and A. This is the sensitivity of these fibers to local anesthetic agents, B, C and A. There is one more classification for it. If you take the individual, then if you take the individual, it is A gamma, A delta, sorry, A gamma, A delta, then B, then C, right? A gamma, A delta, then B, then C. This A gamma, A delta, B and C. This is the sensitivity for O. Now, what is the order of blockade? It is autonomic, sensory, motor. Order of recovery, motor, sensory, autonomic. Order of blockade is autonomic, sensory, motor, and order of recovery is, right? Now, the local anesthetics can be divided into 2 groups: amino esters and aminoamides. Local anesthetics can be divided into 2 groups: amino esters and aminoamides. Now, अगर spelling में single I है, if the spelling is single I, तो ester, if the spelling has 2 I's, amide. Spelling has single I, ester, spelling has 2 I's, amide. Right? Now, amino ester and aminoamides. Now, what is the difference between amino esters and aminoamides? Amino esters, they are metabolized by plasma pseudocholinesterase. Amino esters are metabolized by plasma pseudocholinesterase except cocaine. They are metabolized by plasma pseudocholinesterase except cocaine. They are unstable compounds and they are metabolized to a compound known as PABA, para-amino-benzoic acid, and this PABA is responsible for high incidence of allergic reactions. Amino esters are metabolized to a compound known as PABA, para-amino-benzoic acid, which is responsible for high incidence of allergic reactions. Now, on the other hand, aminoamides are metabolized in liver. They are stable solutions and they have less incidence of allergic reactions. Aminoamides are metabolized in liver and they have less incidence of allergic reactions. Now, you can also divide the local anesthetics based upon duration of action into short acting, for example chlorprocaine, it is shortest acting, right? It is shortest acting, short acting, intermediate acting, for example lignocaine, and third long acting, for example short acting, intermediate lignocaine, and long acting, for example bupivacaine. Now, right? Now, what about the pharmacokinetics of local anesthetics? What about pharmacokinetics of local anesthetics? 1. Absorption. Now, it depends upon site of injection. The absorption depends upon site of injection. Now, more vascular is the site, faster will be the absorption, which will lead to decreased duration of action. More vascular is the site, faster will be the absorption, leading to decreased duration of action. For example, write down peak plasma concentration after single shot of local anesthetic. Peak plasma concentration after single shot of local anesthetic. Peak plasma concentration after single shot of local anesthetic, right? This is intrapleural, then intercostal, then lumbar epidural, and then brachial plexus, right? It is intrapleural, intercostal, lumbar epidural, and brachial plexus. So if you give it in the intrapleural space, it will be absorbed very fast, but if you give it in the brachial plexus, it will be absorbed slowly. So in the intrapleural space, the duration of action will be shorter, but in the brachial plexus, it will be longer. So one is the site of injection. Then second is dose. So higher dosage means longer duration, Smaller dosage means shorter duration. Higher dosage means longer duration, shorter dosage means smaller dosage means shorter duration. And then third is addition of adrenaline. Now when you add adrenaline to local anesthetic solution, this leads to decreased blood flow and this leads to decreased absorption, which will lead to increased duration of action. This will lead to increased duration of action. So when you add adrenaline to local anesthetic solution, this leads to decreased blood flow, leading to decreased absorption, leading to increased duration of action. Now, how does the local anesthetics they exert their effect? Now the local anesthetics are weak bases. The local anesthetics are weak bases. Now what happens is the local anesthetics they act upon nodes of Ranvier. The local anesthetics they act upon nodes of Ranvier. Local anesthetics they act upon nodes of Ranvier. What they do is they enter the axons in undissociated form. They enter axons in an undissociated form, and then inside axons they divide into ionic and non-ionic. They divide into ionic and non-ionic, and then Yeah. Then the local anesthetics, it enters the axons in an undissociated form and divides into ionic and non-ionic, and then this ionic forms, it blocks the sodium channels inside the axons, and once the sodium channels are blocked, the propagation of nerve impulse is blocked. So that is how A gamma, A delta, B and C, that is one of the latest which is fiber wise, but if you club it together then it is B, C and A, because A fibers are the largest and thickest fibers. क्या रिपीट करना है? Okay, so local anesthetics enter the axons in an undissociated form, divides into ionic and non-ionic, and then this ionic form, it blocks the sodium channels inside the axons, and once the sodium channels are blocked, the propagation of nerve impulse is blocked. Now, the pH at which 50% drug is ionic and 50% non-ionic, the pH at which 50% drug is ionic plus 50% non-ionic is known as pKa. Right, is known as pKa. Now, drugs having pKa value closer to physiological pH, drugs having pK value closer to physiological pH are more faster acting than other drugs. Drugs having pK value closer to physiological pH are more faster acting than drugs. For example, lignocaine has a pK value of 7.8 and bupivacaine 8.1. So lignocaine is more faster acting than bupivacaine because it has a pK value closer to the physiological pH. Now, then there is one more thing which is known as differential sensory blockade. What is differential sensory blockade? It is shown by bupivacaine. It is shown by bupivacaine. At low concentration, it only causes sensory block. At low concentration, it only causes sensory block, while at high concentration, it causes sensory as well as motor block. At low concentration, there is selective sensory blockade, while at high concentration, there is sensory as well as motor blockade. For example, when you give bupivacaine in a concentration of 0.125%, it only causes sensory block, and this is used for labor analgesia, because in labor analgesia you do not want the patient to that motor blockade should occur, because if there is a motor blockade, then the bearing down effort will also go away. You only want selective sensory block so that there is selective pain relief, right? And that's why you use low concentration of bupivacaine. And why bupivacaine only? Why not lignocaine? Because lignocaine does not show differential sensory blockade, which is shown by bupivacaine. It has higher tendency to block the sensory fibers than the motor fibers, but at higher dose it will block both. Now, what happens when adrenaline is added to local anesthetic? Addition of vasoconstrictors. Addition of vasoconstrictors. Now, when you add adrenaline, is used in a concentration of 1:2 lakh or 1:1 lakh. Adrenaline is used in a concentration of 1:2 lakh or 1:1 lakh. Now, when you add adrenaline to lignocaine, it increases both the sensory as well as motor block. When you add adrenaline to lignocaine, it increases both the sensory as well as motor blockade. But when you add adrenaline to bupivacaine, it only increases the sensory block. There is no effect upon the motor blockade. If you add adrenaline to bupivacaine, it only increases the sensory block. There is no effect upon the motor blockade. Now, alternative to adrenaline is phenylephrine. It is used in a concentration of 1:20,000 and it causes less tachycardia. That is the only advantage. It causes less tachycardia. Now what happens when you add soda bicarb? What happens when you add soda bicarb to local anesthetic solution? Now, addition of soda bicarb to local anesthetic solution leads to rapid onset of action. It leads to rapid onset of action. Duration of block is increased. Quality of block is improved. Rapid onset of action, duration of block is increased, quality of block is improved, and it causes less subcutaneous pain. Then, what about the toxicity of local anesthetic? Now, the toxicity of local anesthetic basically manifests in CNS and CVS, because both of them have got fast sodium receptor channels. So, it basically occurs in CNS and CVS. Now, in the CNS, what happens in the CNS? In the CNS, the patient complains of lightheadedness, dizziness. The patient complains of lightheadedness, dizziness, followed by auditory and visual disturbances. There will be auditory disturbance and visual disturbance, followed by auditory and visual disturbances. This is followed by muscle twitching, tremors and convulsions. Muscle twitching, tremors and convulsions. Now, what happens in the CVS? Treatment of CNS toxicity includes anticonvulsants and sedatives, benzodiazepines, right? For example, midazolam. In the CVS, all local anesthetics are vasodilators except cocaine. Bupivacaine forms irreversible complexes with the receptors of the heart and therefore should never be given as intravenous injection. Bupivacaine forms irreversible complexes with the receptors of the heart and therefore should never be given as intravenous injection. Now, drugs used for bupivacaine cardiotoxicity are which are the drugs which are used? These include 20% lipid emulsion, second adrenaline, third vasopressin, and fourth atropine. Right? 20% lipid emulsions, adrenaline, vasopressin and atropine. Antiarrhythmics have no standard role. The only role of antiarrhythmics is only when they are specifically indicated. So, for example, you will not use any amiodarone or bratiglium or lignocaine. You will only use them if they are specifically indicated. So, previously this was a standard. Antiarrhythmics has to be used. These days, antiarrhythmics are not the part of standard treatment. They are only used if they are indicated. Right? So, 20% lipid emulsion, adrenaline, vasopressin and atropine. Vasopressin, third point is vasopressin. Right? Then, next is methglobemia. It is seen by prilocaine and benzocaine. It is shown by prilocaine and benzocaine. Treatment is methylene blue. It is shown by prilocaine and benzocaine. Treatment is methylene blue. Then local anesthetic with adrenaline is contraindicated for the ring blockade of penis, pinna, fingers and toes. Why? Because all of them they contain end arteries. It is contraindicated for the ring blockade of finger, toes, penis and pinna. Why? Because all of them they contain end arteries. Contraindicated for the ring blockade of penis, pinna, finger and toes. It is penis because all of them they contain end arteries. Just keep on writing, because once you will go through the notes you will realize what you have written, and all these points right from what I have been telling you from morning have been asked in your exam. What's about methylglobin? It is a male hemoglobin, and it is when you give prilocaine and benzocaine, then methylglobin can occur. Drug treatment for methylglobin is methylene blue, 2 mg per kg body weight. Methylene blue. Now, lignocaine. I told you that treatment for methylglobin is methylene blue. Now, lignocaine. It is most commonly used local anesthetic. It is most commonly used local anesthetic, lignocaine. Concentrations used are 5% heavy for spinal anesthesia, 4% topical anesthesia, 2% epidural anesthesia, 2% jelly for urethral procedures, 1% nerve blocks, and 0.5% for intravenous regional anesthesia. 0.5% for intravenous regional anesthesia. 0.5%. Right? Again, concentrations are very important. They have been asked. Epidural or extradural is the same thing. Epidural, extradural is the same thing. IVRA is intravenous regional anesthesia or Byers block. Or Byers block. Now, concentrations are very important. Questions have been asked many times. Now, what is the dose maximum safe dose is 3 milligram per kg or 300 milligram without adrenaline, and 7 milligram per kg or 500 milligram with adrenaline. Maximum safe dose is 3 milligram per kg or 3 milligram per kg or 300 milligram without adrenaline, and 7 milligram per kg or 500 milligram with adrenaline. This is the maximum safe dose. This is the maximum safe dose. 3 milligram per kg or 300 milligram without adrenaline, or 7 milligram per kg or 500 milligram with adrenaline. Right? Then for bupivacaine, it is long acting, contraindicated for intravenous anesthesia. Long acting, contraindicated for intravenous anesthesia. Maximum safe dose 2 milligram per kg with or without ADR. Sir, should not this dose be opposite? Why? Agroha, you give higher dose with adrenaline because with adrenaline the absorption will be less, so the chances of toxicity will be less. If you give higher dose without adrenaline, more drug will get absorbed and that will lead to local anesthetic toxicity. Now maximum safe dose is 2 milligram per kg with or without adrenaline. Concentrations used are 0.125% for painless labor and 0.5% for spinal or epidural. 0.125% for painless labor and 0.5% for spinal or epidural. Right? Then IVRA or Bayer's block. Now it is used both for upper limb as well as for lower limb. It is used both for upper limb as well as for lower limb. Drugs right, is used both for upper limb as well as lower limb. Drugs used are, drug of choice is prilocaine. Drug of choice is prilocaine. Right, drug of choice is prilocaine. Because it has got better therapeutic competence. Although lignocaine is also used, but drug of choice is prilocaine. 0.5% without adrenaline. Bupivacaine should not be used. Bupivacaine is contraindicated. Contraindications to block are sickle cell disease, scleroderma and Raynaud's disease. Contraindications to block are sickle cell disease, scleroderma and Raynaud's disease. Contraindications are sickle cell disease, scleroderma and Raynaud's disease. right? Then comes AMLA. AMLA is eutactic mixture of, no, I have already told you now, bupivacaine cannot be used intravenously, Srinagar. So you cannot use for IVRA. Now, what about AMLA? AMLA means eutactic mixture of local anesthetics. AMLA means eutactic mixture of local anesthetics. It is a combination of 2.5% lignocaine plus 2.5% prilocaine. Now, it is used to decrease needle phobia. It is used to decrease needle phobia. Many people have fear from venipuncture, so it is used to decrease needle phobia. Now, next is spinal anesthesia. Spinal anesthesia. E means eutactic. Eutactic means easily melting. Right. Now, spinal anesthesia is also known as subarachnoid block. Spinal anesthesia is also known as subarachnoid block. Also known as subarachnoid block. Now, the spinal cord ends either at lower border of L1 or upper border of L2. It ends either at lower border of L1 or upper border of L2. Therefore, spinal anesthesia is most commonly given from L23 to L5S1 space. The spinal anesthesia is most commonly given from L23 to L5S1 space. Right? It is most commonly given from L23 to L5S1 space. Now, what are the structures which are punctured during spinal anesthesia? Structures punctured during spinal anesthesia. What are the structures which are punctured during spinal anesthesia? These include skin, subcutaneous tissue, then three ligaments: supraspinous, interspinous and ligamentum flavum. Supraspinous, interspinous and ligamentum flavum. This is followed by dura and then arachnoid. So these are the structures which are punctured during spinal anesthesia: skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura and arachnoid. So when you puncture arachnoid, the CSF will come out. When you puncture arachnoid, CSF will come out. What are the drugs which are used for spinal anesthesia? These include lignocaine 5% heavy and bupivacaine 0.5% heavy. These include lignocaine 5% heavy and bupivacaine 0.5% heavy. Heavy means the specific gravity of the drugs is more than that of the CSF. So the drug will always go towards the gravity. Because the drug will be heavier, so it will go towards the gravity. Now they are made heavy by addition of dextrose. They are made heavy by addition of dextrose. So when they add dextrose to the local anesthetic solution, the drugs become heavy and then it will go towards the gravity. Then what is the position of spinal anesthesia? Position of spinal anesthesia? Position of spinal anesthesia used is heavy means the specific gravity of the drug is more than that of the CSF. So the drug will go always towards the gravity because it is a heavy drug and it is made heavy by addition of dextrose. Now what is the position of used for spinal anesthesia? Either lateral position or sitting position. Either lateral position or sitting position. Then what are the needles which are used? Needles used are pencil tip needles and non-pencil tip needles. Pencil tip needles and non-pencil tip needles. So when you use pencil tip needles, this leads to decreased incidence of post-spinal headache. This leads to decreased incidence of post-spinal headache. Right? So when you use it. Right? Then comes now then there is nothing like when do we use non-pencil tip needles. The normal needles are non-pencil tip. Pencil tips are specifically asked when we have to, and the pencil tip needles are generally used by the anesthetist only. Otherwise everybody uses non-pencil tip needles, especially the physicians who do lumbar puncture, for example the neurologist, they use the non-pencil tip needles. Then what is site of spinal anesthesia? It can be either median or it can be paramedian. It can be median or paramedian. This can be the site of spinal anesthesia. It can be either midline or it can be median, paramedian. Now, what are the systemic effects of spinal anesthesia? Systemic effects. Now, in the cardiovascular system, you have to tell me dura cutting is non-pencil tip, splitting is pencil tip. When you split the dura, that is done by a pencil tip needle. Cutting the dura is a non-pencil tip needle. Now, what are the systemic effects of spinal anesthesia? Now tell me, out of the sympathetic and parasympathetic, which system is blocked by spinal anesthesia? Spinal anesthesia blocks which system? Sympathetic or parasympathetic? 2 2. Okay, 3 2, 3 3. Okay, 3 centers are saying parasympathetic and 3 centers are saying sympathetic. Okay, now it becomes 4 3, 4 4, 5 4. Achha, 5 centers say parasympathetic. Chalo, I tell you. Spinal anesthesia blocks the sympathetic system. So the parasympathetic becomes dominant. Spinal anesthesia does not block parasympathetic. It blocks sympathetic. So most of you were wrong. Clear? Now, since the spinal anesthesia blocks sympathetic system, the parasympathetic becomes dominant. And since they become dominant, all the effects will be of parasympathetic. For example, in the CVS, sympathetic block, parasympathetic becomes dominant. The blood vessels are dilated. Blood vessels are dilated. This leads to decreased venous return, which leads to decreased blood pressure. Now, since there is a decrease in blood pressure, this causes reflex tachycardia. Right? So, in the cardiovascular system, there is blockade of the sympathetic system, blood vessels get dilated, which lead to decreased venous return, leading to decreased cardiac output and blood pressure, leading to increased tachycardia. Now, if the spinal anesthesia is high enough, if the spinal anesthesia is high enough, सिंपैथेटिक ब्लॉकेड हो रहा है, कार्डियक सिंपैथेटिक ब्लॉकेड नहीं हुई अभी, बट इफ द हाई देयर इज अ हाई स्पाइनल एनेस्थीसिया एंड द कार्डियक सिंपैथेटिक ब्लॉकेड आल्सो अकर्स, दैट कॉजेस ब्रेडिकार्डिया. सो हाई स्पाइनल एनेस्थीसिया कॉजेस hypotension plus bradycardia. Spinal anesthesia causes hypotension with tachycardia. High spinal anesthesia causes hypotension with bradycardia. Why? Because the cardiac sympathetic supply is also blocked, that is T1 to T4 are blocked. Right? Unless T1 to T4 are not blocked, high spinal anesthesia will not occur and there will be not bradycardia but tachycardia. Then what are the causes of hypotension during spinal anesthesia? Causes of hypotension during spinal anesthesia. These are: 1. Decreased venous return. Decreased venous return. 2nd, bradycardia leading to decreased cardiac output. Bradycardia leading to decreased cardiac output. 3rd, blockade of adrenal glands. Blockade of adrenal glands. And 4th, local anesthetic toxicity. And 4th, local anesthetic toxicity. Right? Then comes the CNS. This was the CVS. Then comes local anesthetic toxicity. Last point is local anesthetic toxicity. Then what happens in the CNS? Now in the CNS, out of autonomic, sensory and motor, third point is blockade of adrenal glands. Out of autonomic, sensory and motor, sensory is easiest to test. Now whatever is the sensory level, which is basically tested by pinpricks. So whatever is the sensory level, autonomic blockade is 2 level above and motor blockade is 2 level below. So if a patient has a sensory level of T4, autonomic will be T2 and motor will be T6. Right? Autonomic will be T2 and motor will be T6. That is how you will calculate. Whatever is the sensory level, 2 segments above is the autonomic blockade and 2 segments below is the motor blockade. Then what happens in respiration? Now in respiration, all parameters of respiration remain unaffected. All parameters of respiration remain unaffected except maximum breathing capacity and active exhalation. These are decreased due to blockade of intercostal muscles. They are decreased due to blockade of intercostal muscles. Now, high spinal anesthesia can cause blockade of phrenic nerve. High spinal anesthesia can cause maximum breathing capacity, but in the MBC is maximum breathing capacity. High spinal anesthesia can cause blockade of phrenic nerve, which can lead to apnea. High spinal anesthesia can cause blockade of phrenic nerve, which can lead to apnea. Now, the most common cause of apnea during spinal anesthesia. Most common cause of apnea during spinal anesthesia is decreased blood supply to the brain. Most common cause of apnea during spinal anesthesia is decreased blood supply to the brain. Now, next, what happens in GIT? Now, in GIT, sympathetic blocked, parasympathetic dominant. This will lead to increased peristalsis plus relaxation of sphincters. This leads to increased peristalsis plus relaxation of sphincters. This is known as small contracted gut. This is known as small contracted gut. This is known as small contracted gut. Increased peristalsis with relaxation of sphincters is known as small contracted gut. Then what happens to temperature? Due to dilatation of blood vessels, there is increased heat loss. Due to dilatation of blood vessels, there is increased heat loss, and the patient compensates heat loss by shivering. Due to dilatation of blood vessels, there is increased heat loss. The patient compensates for heat loss by shivering. Then, what happens in the genitourinary system? What happens in genitourinary system? Now, in the genitourinary system, in spite that the parasympathetic is dominant, there will be urinary retention. There is urinary retention. Why urinary retention? Because what happens is passing of urine is a voluntary effort. It is a motor control effort, and the motor gets paralyzed. So what will happen? The urine will start collecting into the bladder, and the bladder size will start increasing. So there will be urinary retention, right? Now, what are the side effects of spinal anesthesia? Are the adverse effects of spinal anesthesia? Now, adverse effects of spinal anesthesia are: 1. Hypotension. Hypotension. Now hypotension can be prevented by preloading the patient. It can be prevented by preloading the patient with 1 to 1.5 liters of fluids. It can be prevented by preloading the patient with 1 to 1.5 liters of fluids. Treatment is vasopressors like mefentramin. Treatment is vasopressors like mefentramin. So when you give mefentramin, that will raise the blood pressure. Then second complication is bradycardia. Treatment is atropine. Second complication is bradycardia. Treatment is atropine. Then third complication is respiratory insufficiency or apnea. Treatment is IPPV plus correction of hypotension. Treatment is IPPV plus correction of hypotension. Then fourth is post spinal headache. Post spinal headache. Now what happens is, when you give spinal anesthesia, you make a small hole in the dura and through which the CSF keeps on leaking. This leak of the CSF pulls the structures downwards, and pulling of the structures downwards which are present behind the brain causes headache, known as post-spinal headache. Now the post-spinal headache occurs 24 to 48 hours after spinal anesthesia. The post-spinal headache occurs 24 to 48 hours after spinal anesthesia. The headache is usually occipital in origin. The headache is usually occipital in origin. But in what happens is, you make a small hole in the dura and through that hole the CSF keeps on leaking. This leak of the CSF pulls the structures downwards, right, and pulling of the brain structure downwards causes headache, known as post-spinal headache. Urinary retention occurs because the parasympathetic is dominant, sympathetic blocked. Still urinary retention occurs because passing of urine is a voluntary effort, motor controlled effort, and the motor gets paralyzed. So motor is paralyzed, so patient cannot pass the urine on its own. That's why there will be urinary retention. Now spinal anesthesia will obviously cause sacral block. The spinal anesthesia causes blockade up to T4, T2. So below that all of them is blocked. So headache is usually occipital in origin. Now it is a low pressure headache. It is a low pressure, unlike meningitis which is a high pressure headache, this one is a low pressure headache. Right? It is a low pressure headache. Now the headache can be prevented, one, by using pencil tip needles. Now what does pencil tip needles do? They do not cut the dura, but they cause splitting of the dural fibers. So when the needle comes out, the fibers, they come back at their own place. So no hole is formed and no CSF leak occurs. So you can prevent it by using pencil tip needles. Second, by using higher gauge needles. By using higher gauge needles. because higher the gauge, more smaller, more thinner will be the needle, so CSF leak will be less. Third, adequate hydration. And fourth, patient moves minimum in the post-operative period. Fourth, patient moves minimum in the post-operative period. Patient moves minimum in the post-operative period. Treatment involves lot of analgesics. Treatment is lot of analgesics, correction of dehydration, lot of analgesics, correction of dehydration, and epidural blood patch and epidural blood patch. You take blood from the antecubital fossa and inject it into the epidural space. The blood will clot there and it will form a seal over the dural puncture site. Then next complication is epidural hematoma. This can cause paraplegia. Epidural hematoma, this can cause paraplegia. Then paralysis of cranial nerves. Paralysis of cranial nerves. Paralysis of cranial nerves. Sixth nerve is most commonly involved, while 1, 9th and 10th nerves never involved. Sixth nerve is most commonly involved, while 1, 9th and 10th nerves are never involved. Paralysis of cranial nerves. It is permanent paralysis. It may resolve slowly and steadily over the time, but initially it is permanent. This is a complication now. It is not an effect, it is a complication. Then what else can occur? There can be meningitis, because you are meningitis, and there can be backache. There can be meningitis and there can be backache, right? Now, what are the absolute contraindications of spinal anesthesia? What are the absolute contraindications of spinal anesthesia? Absolute contraindications include cranial nerve palsy occurs. Why? Because when the structures are pulled downward because of the low pressure, pulling of those structure downward, it also causes the nerve to pull down, and pulling of nerve in a downward direction causes paralysis. Now, absolute contraindications include raised ICT. If you put a lumbar puncture in a raised ICT, that will result in transternal herniation, so it should not be done. Raised ICT. Second, refusal of the patient. If the patient do not give consent, then spinal anesthesia should not be given. So refusal of the patient is another contraindication. Third, severe hypovolemia. Fourth, severe mitral or aortic stenosis. Fifth, infection at the local site. Infection at the local site. And sixth, coagulopathy. Coagulopathy. Now, coagulopathy can be due to decreased platelet, high NR, hemophilia, any type of coagulopathy is contraindication for spinal anesthesia. It should not be done. Right? Hypovolemia, not the hypovolemia but the severe hypovolemia. Reason being it causes vasodilation, and if the patient is severely hypovolemic there will be vasoconstriction, and if you give spinal anesthesia that will cause vasodilation and that will lead to further fall in blood pressure. So that's why in severe hypovolemia again it is absolutely contraindicated. Now for cesarean section a level of T4 to S5 is required. For cesarean section a level of T4 to S5 is required. Remifentanil should not be used for spinal anesthesia. Remifentanil should not be used for spinal anesthesia. Remifentanil should not be used for spinal anesthesia. It contains glycine which causes neurotoxicity. It contains glycine which causes neurotoxicity. Agro, I am just coming to the last CPR part, another 5-10 minutes. It contains neuro. Now, for all heart diseases in pregnancy, epidural is the choice. For all heart diseases in pregnancy, epidural is the choice. Right? Now, write down the last topic, CPR, cardiopulmonary resuscitation. CPR, T4 to S5, root level, S5. Now CPR, the sequence for CPR is compressions, airway and breathing. The sequence for CPR is compressions, airway and breathing. You should remember that in a patient having central pulses, the compressions should have not to be done, because the patient will already have an heart. So please remember that CPR is only meant when you cannot feel any central pulse and the patient has a cardiac arrest. So compressions, airway and breathing. Now the compressions are given. Which surgery can be done under spinal anesthesia? Any surgery below the umbilicus level, up till can be done safely under spinal anesthesia. Now the compressions are given at a rate of 100 per minute. The compressions are given at a rate of 100 per minute. The compressions are given in the center of the chest. The compressions are given in the center of the chest. The compression should be at least 2 inches in depth. The compressions should be at least 2 inches in depth. Then compression to ventilation ratio for adult 30:2, for child 30:2, and 15:2. 15:2 if there is more than one double rescuer. 30:2 single rescuer. Right? In children it is 30:2 if there is single rescuer and 15:2 if there is double rescuer. Then the drug of choice for CPR is adrenaline, 1:1000 IV. Drug of choice for CPR is adrenaline, 1:1000 IV. Now for hypovolemic shock or hypovolemic hypotension it is 1:10,000 IV, and for anaphylaxis it is 1:1000 intramuscular adrenaline dose. 1:10,000 IV for shock patients, and for anaphylaxis 1:1000 intramuscular. Now the most common ribs fractured during CPR are 5, 6 and 7, because the first 4 ribs are supported by the shoulder girdle. So 5, 6, 7 are floating ribs, so they are basically most commonly broken during CPR. Now dextrose containing fluid should not be used in CPR. Dextrose containing fluids should not be used in CPR because they increase cerebral edema. They increase cerebral edema. Normal saline is preferred. Normal saline is preferred. Then drugs, atropine is not included in routine CPR. Atropine is not included in routine CPR. According to AHA, American Heart Association 2010 guidelines, atropine is not the part of routine CPR. So it is not included in routine CPR. Then which are the drugs which can be given through the tracheal route? These include adrenaline, atropine, naloxone. Now what are the drugs which cannot be given through the tracheal route? Not given. These include noradrenaline, soda bicarb, beryllium and calcium salts. These are the drugs which should not be given through the tracheal route: noradrenaline, soda bicarb, beryllium and calcium salts. The drugs which can be safely given are adrenaline, atropine and naloxone. Of course you will require a higher amount of drugs when you give it through the tracheal route. Third drug is beryllium, naloxone. Right? Now the thing you have to do, people, you have to do is you have to combine these notes along with the DAMS booklet and plus the MCQs. There are, whatever guide you do, that is not a Srinagar, you check the textbooks. It is clearly written the first 4 ribs are supported by the shoulder girdle and therefore they are not broken. 5, 6 and 7 are more commonly broken during CPR. So I am not, I will just ask you or request you, you should yourself see the textbook and then decide about it. Whatever I have told you today is 100% authenticated by the textbook. So I can, right? Now another thing is why only sympathetic blockade in spinal anesthesia. It is a selective blockade. So it is only the drugs have a more affinity towards those fibers. So that's why it is only a sympathetic blockade occurs. See, my name is Dr. Arvinder Singh and I am on the DAMS Facebook page. So if you have any anesthesia query, you can just put it on the DAMS Facebook page and I will be very happy to answer it. But I don't take opioids. It has been long time that I have not taken opioids, so that's why I will not be very comfortable taking it, because it's not used if you cannot. I cannot take it properly. Coagulopathy is an absolute contraindication, because if there is a coagulopathy, there can be a bleeding, and that bleeding can cause epidural hematoma, which can lead to paraplegia. And that paraplegia, if go undetected, it can cause permanent damage. So that's why. See, the breastfeeding infants are on milk, so the ideal fasting period for them is 4 hours. But if you want to give water, you can give water to the infant, but at least that is also up till 2 hours before. And happy Diwali to all of you. And another thing is, best of luck to all of you for your exams. Your exams are also very near. Atypical pseudocholesterase is the abnormal pseudocholesterase, right? It is a low quantity of pseudocholesterase which causes choline apnea. That is known as atypical pseudocholesterase. Right? So I will be there on the Facebook page to very happy to answer all of your questions. So good luck to all of you and bye.